There is a stretch of land in northeast Philadelphia where concrete buildings still stand, long after the institution that built them was shut down. They are not small structures. These are multi-story wards, reinforced concrete, narrow windows, heavy steel doors still attached in some places. The hallways run long and straight, designed for movement, supervision, control. Paint has peeled away from the walls, exposing older layers beneath. Pipes run along the ceilings, some broken, some hanging loose. This was the Philadelphia State Hospital at Byberry. It opened in 1907 as part of Pennsylvania's expanding mental health system, a state-funded institution built to treat psychiatric patients who could not be managed elsewhere. At the time, it was presented as a solution, a controlled environment, a place where care could be standardized. The official records describe it in administrative language: capacity expansion, patient accommodation, state responsibility. But the physical layout tells a different story. The buildings were designed to hold large numbers of people, not temporarily, but indefinitely. Long wards, shared sleeping areas, minimal privacy, systems built not for recovery, but for containment. And yet, even those structures were not enough, because within a few decades, the number of patients inside Byberry exceeded what the facility was designed to handle. The wards filled, then they overflowed. I came across Byberry while reviewing state hospital infrastructure records, trying to understand how facilities expanded during periods of population growth and wartime pressure. But one detail did not align with the rest of the data. In 1946, the conditions inside this hospital were not just recorded. They were exposed to the entire country, published, photographed, distributed in one of the largest magazines in the United States. And still, the hospital remained open, not for a few years, for decades, which raises a specific question. If the conditions inside Byberry were publicly documented in 1946, why did the institution continue operating until 1990? The answer begins with number. By the mid-1940s, Byberry State Hospital was operating far beyond its intended capacity. Official records from that period indicate a patient population exceeding 6,000 individuals. Some estimates place it closer to 7,000 at its peak. The facility was not designed for that number. In fact, available data suggests that Byberry was operating at approximately 75% above its intended capacity. That is not a marginal overflow. That is systemic overload. But the patient count is only part of the equation. Because a hospital is not defined by how many people it holds, it is defined by how many people it can care for. At the same time that patient numbers were rising, staffing levels were not keeping pace. Records indicate that Byberry employed approximately 14 physicians during this period, 14 doctors for over 6,000 patients. That creates a ratio of roughly 1 doctor for every 400 individuals. In some wards, the imbalance was even more extreme. Attendants, the staff responsible for daily supervision, were assigned to groups of 300 or more patients at a time. These are not estimates drawn from anecdotal accounts. These figures appear in state reports and institutional records. The official explanation acknowledges the strain: wartime conditions, budget limitations, staff shortages due to military service. But those explanations do not resolve the underlying contradiction, because even under constrained conditions, the gap between capacity and population remained unaddressed for years. No rapid expansion, no mass relocation, no structural correction that matched the scale of the problem. Instead, the system continued operating with the same imbalance: thousands of patients, minimal staff, limited oversight. And when systems reach that level of imbalance, outcomes are no longer theoretical. They become visible, not in reports, but in what people inside the system begin to see, and, in some cases, document. There were individuals working at Byberry who were not part of the administration, not part of the policy decisions. They were attendants, orderlies, assigned there during wartime, and some of them left behind a record that did not match the official language. One of those individuals had access to something most staff did not: a camera. On May 6, 1946, Life magazine published an article titled Bedlam 1946. It was not a routine feature. The article contained a series of photographs taken inside Byberry State Hospital, images that had not been staged, not arranged, not filtered through institutional approval. They showed the interior of the wards as they existed at that time: patients seated on bare floors, without clothing, men crowded together in confined spaces, pressed against walls, individuals restrained to benches, unable to move freely. The photographs were accompanied by descriptions that compared the conditions to those found in wartime detention facilities. This was not internal documentation, this was national exposure. The magazine had a circulation in the millions. The images were distributed across the United States, reaching households, policymakers, medical professionals, and state officials. For the first time, the conditions inside Byberry were no longer confined to reports or internal complaints. They were visible. The record of that publication is clear. The date is fixed. The images remain preserved in archives. This is the point in the timeline where the system becomes fully visible to the outside world. A moment where documentation transitions into public knowledge. And in most cases, moments like this produce immediate structural change. Investigations, closures, reforms implemented under pressure. But the Byberry record does not show an immediate shutdown. It shows continuation. The hospital did not close in 1946. It did not close in 1947. It continued operating for decades after those images were published, which means the exposure itself is not the full explanation, because those photographs did not appear on their own. They were taken by someone inside the system, someone who saw the conditions directly and made a decision to document them. The record identifies him, but what he saw and why it did not immediately change the system requires looking at who he was and what happened after the images left his hands. The photographs, published in May 1946, did not originate from an official inspection. They were taken by someone working inside the hospital, someone without authority, without institutional backing, and without control over what happened next. His name was Charlie Lord. Lord was not a physician. He was not part of the administrative staff. He was a conscientious objector during World War II, assigned to civilian service instead of military duty. That assignment placed him inside Byberry State Hospital as an orderly. His role was functional. He moved patients, maintained wards, followed instructions. But unlike most attendants, Lord had access to a camera, and over time, he began to use it. The images he captured were not taken in a single moment. They were taken across shifts, across days, documenting what he was seeing repeatedly: overcrowded wards, patients without adequate clothing, individuals restrained or left unattended for extended periods. These were not isolated incidents. The consistency of the images suggests repetition. Lord did not publish the photographs himself. He passed them on. They eventually reached Life magazine, where they were selected, printed, and distributed nationally in 1946. At that point, the images were no longer his. They became part of the public record. But his position inside the system ended where the publication began. There is no record of Lord leading reforms, no indication that he was brought into institutional decision-making after the exposure. He documented, he transferred the evidence, and the system continued operating around that evidence, which creates a structural problem. Because when a system is exposed from the inside and continues without immediate interruption, the issue is no longer visibility, it becomes response. And in this case, the response did not match the scale of what had been documented. To understand that gap, it is necessary to look at what else was happening at the same time. not inside the wards, but within the system responsible for managing them. Now consider the timing. 1946. The conditions inside Byberry are documented and published nationally. Photographic evidence, public distribution, institutional visibility. That same period marks the beginning of broader discussions in the United States around psychiatric reform. Reports on overcrowding were not limited to a single hospital. They were part of a wider pattern across state institutions. By the early 1950s, new psychiatric medications began to enter clinical use. Among them was chlorpromazine, introduced as a treatment intended to stabilize severe psychiatric conditions. The official narrative describes this period as a transition, old systems under strain, new treatments emerging, gradual reform taking place over time. But the timeline does not fully align with that explanation, because despite national exposure in 1946 and despite the introduction of new treatment methods in the years that followed, Byberry did not undergo immediate structural correction. It did not reduce its population to match capacity. It did not expand staffing at a rate proportional to patient load. Instead, the institution remained operational, under the same state authority, in the same location, with many of the same structural limitations. This creates an anomaly that the official narrative does not directly resolve. A facility publicly documented as overcrowded and under-resourced continued functioning for decades during a period when reform was already being discussed and, in some cases, implemented elsewhere. One explanation is administrative delay, another is resource limitation, but neither explanation accounts for the duration. Because delay explains months, it may explain years. It does not, on its own, explain continuity across 4 decades. And that continuity introduces a different question, not about conditions, but about records, because systems of this scale generate documentation, admissions, transfers, incidents, decisions. If the conditions were known, and the institution remained open, then those decisions exist somewhere in the record. The question is not whether they were made. The question is where they are, and who had access to them. State hospitals operate within layered record systems. Patient files are maintained separately from administrative reports. Internal investigations are documented independently from public summaries. Policy decisions move through departments, committees, and oversight bodies. At Byberry, many of these records were created, but not all of them are fully accessible today. Patient records, by law, remain sealed under privacy protections. They contain names, diagnoses, treatment histories, information that is not released publicly. Administrative records from mid-20th century state institutions are distributed across archives. Some are preserved, others are incomplete. What is missing is not the existence of documentation, but the continuity of it. There is no single, continuous file that traces decision-making from the moment of national exposure in 1946 to the final closure in 1990. Instead, the record appears in fragments. Inspection reports, budget summaries, occasional investigations, each confirms a piece of the system. None provide a complete chain of accountability. This has a specific consequence. It means the conditions can be proven, the exposure can be verified, the timeline can be established, but the exact sequence of decisions, who reviewed the exposure, who approved continued operation, who delayed closure, is not preserved in a single accessible record. By the time the hospital was officially closed in June 1990, the administrative structure that managed it in the 1940s no longer existed in the same form. Personnel had changed, departments had reorganized, records had been archived, relocated, or restricted, which brings the first question closer to its answer. The hospital did not remain open because the evidence was hidden. It remained open within a system where responsibility was distributed, across departments, across decades, across records that were never consolidated into a single, accountable narrative. And by the time the institution finally closed, the impact of that continuity was no longer administrative. It was human, measured not in reports, but in the people who remained inside those walls while the system continued to operate around them. By the time Byberry State Hospital officially closed in June 1990, nearly half a century had passed since those first photographs were published. 44 years. That number matters because it represents the gap between exposure and termination. And inside that gap were not policies or reports or administrative delays. There were people, thousands of them, patients who entered the institution at different points across those decades, some in the 1940s, others in the 50s, 60s, 70s, each one processed through the same system that had already been publicly identified as overcrowded and under-resourced. Not all of them stayed for decades, but many did. Long-term institutionalization was not an exception in mid-20th century psychiatric care. It was a pattern, which means that for a significant number of individuals, Byberry was not a temporary facility. It was where they spent a measurable portion of their lives. Years, in some cases, entire adult lifetimes. And within that time frame, the system around them changed externally. New medications were introduced. Public attitudes toward mental health began to shift. Policies were discussed, revised, debated. But internally, the pace of change did not match the pace of awareness. That difference is difficult to quantify in reports, but it becomes visible when you look at duration. A patient admitted in the late 1940s could have remained inside into the 1960s or beyond, experiencing multiple phases of policy change without leaving the same physical environment. The system evolved. The structure remained. And for those inside it, that distinction was not theoretical. It was lived. This is where the timeline stops being abstract, because the question is no longer why the hospital remained open. The question becomes what that continuity meant for the individuals inside it, not in terms of policy, but in terms of experience. And that is the part the official record does not fully capture, because institutional records track admissions, discharges, treatments. They do not measure time the way a person experiences it. They do not record what it means to spend years in a place that was already known, publicly, to be operating beyond its limits. Which leads back to the core issue. The photographs prove the conditions existed. The reports confirmed the numbers. The system acknowledged the strain. And yet the institution continued. Not invisibly, not secretly, but in full view. Documented, reported, and still operational. So the final question is not about what happened. That part is established. The final question is about how it was allowed to continue for as long as it did, after it was already known. And that answer does not exist in a single document. It exists in the space between them, in the years between exposure and closure, in the decisions that were made and the ones that were delayed, and in the fact that when the doors finally closed in 1990, the system did not provide a single complete explanation for the time in between. The building is gone. Byberry State Hospital was demolished years after its closure. The physical structure, the wards, the corridors, the overcrowded rooms, no longer exist in the form they once did. What remains are fragments. Archived photographs, scattered reports, partial records stored across different institutions, enough to confirm that it happened, not enough to fully explain why it continued, because every major point in the timeline is documented but never fully connected. 1946 exposure, 1950s early psychiatric reform discussions, 1960s, 70s, policy shifts and deinstitutionalization efforts, 1990 final closure. Each stage exists, but the chain between them is incomplete. There is no single document that says, this is why the hospital remained open for 44 years after it was exposed. Instead, there are only pieces, and when a system leaves behind pieces instead of a complete record, it doesn't erase the event. It erases the accountability. So what happened at Byberry is not hidden. It is recorded, photographed, published. But what's missing is the part that should be the most visible, the decision-making that allowed it to continue, because systems don't run on their own. They are maintained, reviewed, approved, again and again, over time. And in this case, those approvals existed, somewhere, but not in a form that tells a complete story. So the question isn't whether people knew. They did. The question is, what happens when something is exposed and nothing changes fast enough to stop it? Because Byberry wasn't hidden. It was seen, and it still continued. The evidence was never erased, only the explanation was.